Hi, today we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. This slide set is part 1 of 3 on eye disorders causing transient or sudden visual loss in this chapter. In this set of slides, we will discuss 5 etiologies, namely amaurosis fugax, anterior ischemic optic neuropathy, posterior ischemic optic neuropathy, optic neuritis, and Leber's hereditary optic neuropathy. Amaurosis fugax refers to a transient ischemic attack of the retina. Because neural tissue has a high rate of metabolism, interruption of blood flow to the retina for more than a few seconds results in transient monocular blindness, a term used interchangeably with amaurosis fugax. Patients describe a rapid fading of vision like a curtain descending, sometimes affecting only a portion of the visual field. Amaurosis fugax usually results from an embolus that becomes stuck within a retinal arteriole. In rare instances, amaurosis fugax results from low central retinal artery perfusion pressure in a patient with a critical stenosis of the ipsilateral carotid artery and poor collateral flow via the circle of Willis. Retinal arterial occlusion also occurs rarely in the following conditions. Marked systemic hypertension causes sclerosis of retinal arterioles, splinter hemorrhages, focal infarcts of the nerve fiber layer known as cotton wool spots, and leakage of lipid and fluid known as hard exudate into the macula. In hypertensive crisis, sudden visual loss can result from vasospasm of retinal arterioles and retinal ischemia. Ophthalmoscopy reveals zones of whitened edematous retina following the distribution of branch retinal arterioles. Complete occlusion of the central retinal artery produces arrest of blood flow and a milky retina with a cherry red fovea. Emboli are composed of cholesterol or Hollenhurst plaque, calcium, or platelet fibrin debris. The most common source is an atherosclerotic plaque in the carotid artery or aorta, although emboli also can arise from the heart, especially in patients with diseased valves, atrial fibrillation, or wall motion abnormalities. Anterior ischemic optic neuropathy is caused by insufficient blood flow through the posterior ciliary arteries that supply the optic disc. It produces painless monocular visual loss that is sudden in onset, followed sometimes by stuttering progression. The optic disc is edematous and usually bordered by nerve fiber layer splinter hemorrhages. There are two forms, arteritic and non-arteritic. The non-arteritic form is most common. Evidence is strong that a crowded disc architecture and small optic cup predispose to the development of the non-arteritic form. There is no treatment available and glucocorticoids should not be prescribed. About 5% of patients, especially Caucasian females aged more than 60, develop the arteritic form in conjunction with giant cell temporal arteritis. It is urgent to recognize the arteritic form so that high doses of glucocorticoids can be instituted immediately to prevent blindness in the second eye. Tocilizumab is an effective alternative to glucocorticoids for sustained suppression of symptoms of giant cell arteritis. The sedimentation rate and C-reactive protein levels are usually elevated. In a patient with visual loss from suspected arteritic anterior ischemic optic neuropathy, temporal artery biopsy is mandatory to confirm the diagnosis. Posterior ischemic optic neuropathy is an uncommon cause of acute visual loss. It is induced by the combination of severe anemia and hypotension. Cases have been reported after major blood loss during surgery, shock, gastrointestinal bleeding, and renal dialysis. The fundus usually appears normal, although optic disc swelling develops if the process extends anteriorly far enough to reach the globe. Vision can be salvaged in some patients by immediate blood transfusion and reversal of hypotension. Optic neuritis is a common inflammatory disease of the optic nerve. Most patients experience ocular pain, especially with eye movements, and have optic disc swelling. In most patients, the demyelinating event was retrobulbar, and the ocular fundus appeared normal on initial examination, although optic disc pallor slowly developed over subsequent months. Virtually all patients experience a gradual recovery of vision after a single episode of optic neuritis, even without treatment. It was reported in optic neuritis treatment trial that the 15-year cumulative probability of developing clinically definite multiple sclerosis after optic neuritis is 50%. A particularly severe form of optic neuritis occurs in neuromyelitis optica. Detection of circulating antibodies directed against aquaporin 4 is diagnostic. Treatment for acute episodes consists of glucocorticoids and, in resistant cases, plasma exchange. Leber's hereditary optic neuropathy usually affect young men, causing gradual, painless, severe central visual loss in one eye, followed weeks to years later by the same process in the other eye. It is caused by a point mutation at codon 11778 in the mitochondrial gene encoding nicotinamide adenine dinucleotide dehydrogenase, subunit 4. Mitochondrial mutations that cause Leber's neuropathy are inherited from the mother by all her children, but for unknown reasons, daughters are rarely affected. This ends part 1 of the slide set for transient or sudden visual loss. Next set of slides will deal with 5 more eye disorders that cause transient or sudden visual loss.